Good evening, all. Hope I am audible to everybody. नमस्कार सभी लोगों को. मैं डॉक्टर मोनिका शशांक हूँ, मेडिकल डायरेक्टर डॉक्टर बीलाल क्लिनिकल लेबोरेटरी में. I welcome you all, the August gathering of all the scientific experts from the industry. जैसा कि आप सभी जानते हैं, diagnostics has become an integral part of clinical management of the patient. Keeping in this mind, we started the doc talk session where we are trying to establish a dialogue between the lab experts and the clinicians. The endeavor is the better patient outcomes. In continuation with the Doc Talk series, this webinar, we have taken a very special topic, the breast cancer, which is the second common cancer in females next to cervical cancer. Why breast cancer? We have taken this topic for today's webinar because if I tell you the global estimates, the numbers, the statistics, these are very, very shocking. As per global estimates about the burden of breast cancer in India, every one woman is diagnosed with breast cancer in every 4 minutes, and one woman dies of breast cancer in every 8 minutes. So this needs a real discussions and understanding how we can diagnose and how we can monitor the treatment of the breast cancer patient. In the breast cancer, HER2 NEU is a molecular oncogene which is expressed, and it is amenable to treatment also with the targeted biotherapies. This means a personalized medicine is also available for breast cancer treatment. So in today's discussion, we have Dr. Anjali with us as a speaker. Dr. Anjali, although she doesn't need any introduction, but I would definitely like to inform you all. She is a director of Center of Excellence for Oncopathology at Dr. Wheeler Laboratory. She is pioneer in the field of surgical pathology, molecular oncology, and the cases which she has reported, more than 15 lakh cases of biopsies, 60,000 IC markers, and many more numbers of cytology. Many papers published in national and international journals, and she has represented organizations in various international and national conferences. So has she received acknowledgements and rewards from various societies and various institutes. So with this experience, I'm very sure that in this webinar, we are going to learn from the best of the leader of the industry. I welcome Dr. Anjali. Please take it forward from here.
Thank you, Dr. Monika, for the kind words. I think straight away we will be proceeding towards the presentation. Just I'm sharing my slides. Is it visible clearly? Dr. Monika, can you see my screen?
Yeah, it's visible. It's visible.
Okay, okay. So I think I can start with it. So the today's topic is that we'll be discussing about the current challenges and future prospects of HER2 NEU reporting in breast cancer cases. So HER2 NEU, we all know that it is a oncoprotein which encodes for HER2 protein, and this HER2 protein is actually a receptor on the breast cells which receives signals to stimulate the growth. And in malignant lesions, it is either overexpressed or is amplified. Once it is overexpressed, it can be studied by ISC. If it is amplified, it can be studied by ISH, that is in situ hybridization. In more than 95% of the cases, the gene overexpression is due to amplification. Therefore, ISC is used as a screening test for gene amplification. And ISH, which is a more skilled, costly test, is done only when the results of ISC are equivocal. And trastuzumab is the drug, which is a targeted drug once this HER2 test is positive. Here you can see that this is ISC slide showing 3+ positivity, and this is a slide of FISH. Why HER2 NEU testing is required? Because it is not only an independent prognostic marker, but is also an independent predictive marker. When the HER2 test is positive, it means that the prognosis of disease is very poor. It is an aggressive type of disease, and there are more chances of metastasis. And as a predictive marker, it identifies the patients who will be benefited by anthracycline-based chemotherapy, and it also determines eligibility for anti-HER2 therapy. Now, the question is when HER2 testing is to be done, which is a very common question. And the answer to it is that in all primary invasive breast carcinomas, at the time of diagnosis, it should be done. Not only at the time of diagnosis, but if the tumor is coming as a recurrent lesion or if it is coming as a metastatic lesion, it should be retested. Why? Because the population of tumor cells which is in the recurrent lesion or in the metastatic lesion is biologically different from that of the primary invasive carcinoma. Meaning thereby, if the HER2 test was negative at the time of diagnosis, it doesn't mean that necessarily recurrent and metastatic lesions will also be negative. So it should be retested once the lesion is recurrent or is metastatic. If a core biopsy shows a negative HER2 results and the tumor profile doesn't match, then also it should be repeated on the resection specimen. If there are multiple foci of invasion, microinvasion, then the larger component are to be tested. But if smaller component is showing any high degree or different grade, then it should the smaller component should also be tested. So the guidelines for HER2 reporting originally were published in 2007, and 7 years later in the 2014 they were updated, and then the focused guidelines were published in 2018, and the latest guidelines are those which were published in the 2023. And these are the guidelines which were released by the ESCO and CAP, and the joint partners were American Society of Medical Oncology. So the latest HER2 updates which were published in the 2023 are just a reaffirmation of those of 2018 updates, and they were just propelled by the results of Destiny 4 breast trial. What does this trial says? This trial says that low HER2 cases are also benefited by the antibody drug conjugate. And just after the result of this Destiny 4 breast trials, the FDA has given expanded approval of this drug, that is trastuzumab deruxtecan, for not only HER2 3+ positive cases, but also to include those cases which shows ISC 1+ or 2+ results with ISH negative. But Destiny 4 trial did not include ISC HER2 0 cases. So guideline says that there are pre-analytical and analytical factors which affect the ISC HER2 results, and they are to be mandatorily recorded in the along with the HER2 reports. So what are those factors? Number one is cold ischemic time. What is that cold ischemic time? It is the time gap between removal of tissue from the patient's body till it is immersed in the formalin, and it should not be more than 30 to 60 minutes, and it should be mandatorily recorded. Then the type of fixative should not be other than 10% neutral buffer formalin. The duration of fixation should be at least 6 hours. And if the tissue is treated by any chemical which affects immunoreactivity, like decalcification, especially in the bone cases, then this should be mentioned in the report. And the status of the control, external control, to be mentioned, as there is no internal control for the HER2, so external control should be mentioned. Adequacy of the sample to be commented. Primary antibody clone which is used, and it's a regulatory status, that is FDA cleared or is a lab LTD, this should be mentioned. The reporting of ISC results are done in 4 categories: 0, 1+, 2+, and 3+. If there is no staining as is seen in this figure, that is negative. Or if less than 10% cell shows faint or barely perceptible positivity, this is again 0. ISC 0 stain. If the like in this figure, if ISC score is ISC showing more than 10% faint positivity, then this is 1+. If moderate staining is seen in more than 10% cells like this, or if complete intense staining is in the less than 10% cells like this complete staining, then this is 2+. And like final case, that is ISC 3+, when you can see the complete O or complete ring at the membrane positivity. And as per the latest guidelines, this and this category, ISC 1 plus and 2 plus with H negative, these two categories can be reported as HER2 low category. So this is the algorithm for ISC HER2 results. If more than 10% complete positive, you will call it ISC 3 plus and will be considered as HER2 positive. Less than 10% complete intense or moderate staining in more than 10%, it will be called ISC 2 plus and it will be considered as equivocal. If faint staining in more than 10%, this will be called ISC 1 plus and will be considered as negative. If there is no staining or less than 10% cell shows faint staining, this is ISC 0 and will be considered as negative. So how will you proceed in equivocal cases? There are two approaches. Number one is either you order for a test on a new specimen, and what this new test will be there on the new specimen. It can be ISH, that is in situ hybridization, or it can be ISC. Or you can order and reflex test on the same specimen, that is ISH on the same specimen. Then is in situ hybridization. According to the probe used, it can be single probe or a dual probe. Single probe is HER2 probe, and what you are supposed to write in the report in the single probe, the number of HER2 signal per cell, the percentage of cells showing amplified signals and heterogeneous signals. In dual probe, you are supposed to write average number of HER2 signal per cell, average number of CP17 signals, and importantly, HER2 is to CP17 ratio. So there are some important issues when the interpretation of ISH tests are done. Number one is that it should always and always be considered in the invasive element and not in the DCIS component. Then how will you select this invasive component in ISH slide? Because there is no background in the fish, you can't identify what type of cell it is. So before you are evaluating ISH, it is mandatory to see HNE or ISC slide to decide for the area which is showing invasive component. And amplification can be studied either by studying number of HER2 gene or the ratio. In majority of the cases, both methods give same results. So according to the method used, it can be FISH, that is fluorescent in situ hybridization. The disadvantage of using FISH is that you can't see the background or morphology. Then other is chromogenic in situ hybridization, where you can see the morphology. This is added advantage. And other is SHISH, that is silver in situ hybridization. Then the newer is D-dish, that is dual color, dual hapten, bright field in situ hybridization. But this dish category has not been mentioned in the CAP guidelines. Although this is a good alternative to the fish, but inter-observer variability is very high in D-dish. So the results of in situ hybridization are given either as positive or negative or cannot be determined. So this is how you see in the single probe. If the number of gene copy is less than 4, straight away this is negative. If number of gene copy is more than 6, it is straight away positive. If the number of HER2 gene copy per cell is falling somewhere between 4 and 6, and then concurrent ISC or dual fish is mandatory. And the dual fish ISH group are well defined in the CAP guidelines. If the ratio is more than 2, and if number of HER2 signal is more than 4, it is group 1, that is straight away positive. If ratio is less than 2 and number is less than 4, it is straight away negative. But if your case is falling in group 2, 3 and 4, then concurrent ISC will be required for the final decision. And these are some images of the fish testing. And how do you read it? You count the signals of the same size. Here you can see in this figure that these are two signals of the same size. But importantly, they should be separated by a distance which is equal to the diameter of single signal. See, here this is the diameter of this cell, this signal, and the distance between these two signal is at least equal to the diameter of single signal. So these are two orange signal and one green signal. What will happen in this case if we are using a dual probe? Here you can see only two green signals. There is no orange signal. So you will not count this cell. What is happening here? You can see 1, 2, 3, 4, 5, and here are two signals, but you will count them as single. Why? Because the gap between two signal is less than the diameter of single signal. So there are 6 orange and 3 green. What is happening here? Again, you will count this as a single. So this is a normal cell where 2 green, 2 orange signal, And here the HER2 is green, which is showing amplified. So how do you report the cases? In group 1 and group 5, the picture is very clear. The group 1 is considered as positive, group 5 is negative. But if your case is falling in group 2, 3 or 4, then concurrent review of IC slide is mandatory, especially in case of group 3, where HER2 signal is more than 6. Here, if the IC results are 0 or +1, this will be negative. If the results are 2 plus or 3 plus, this will be positive. So for group 2, 3 and 4, the final results will be based on concurrent review of ISC slides and recounting of ISH slides by the second reviewer, especially if the ISC is 2 plus. So this is the algorithm for a single probe. Number of gene copy more than 6, ISH positive, less than 4, ISH negative. If falling between 4 and 6, then see the ISC results, concurrent ISC 3 plus or dual fish group 1, this is positive. If concurrent ISC 0 plus 1 or dish or the dual ish is 5 group, this is negative. If concurrent ISC is 2 plus, in that case, dual ISH is to be performed. Then there are some troubleshoots also. Can ISC results be false positive? And the answer is yes, they can be false positive. When it can be false positive? If you are looking a core biopsy and you see that the periphery of the cell is showing darker staining and central part is showing no staining, then this is an edge artifact. So you should be cautious while reading the results. And if the cytoplasmic false positivity is seen, at times it can be so strong that it obscures the membrane staining and it is difficult to read the results. If you are not using RTU and the concentration of antibody is too high, it can cause overstaining. And if HER2 scoring is being done in DCIS component, then you can falsely report it as positive. Then false negative results can also occur if there is prolonged cold ischemic time, if there is tumor heterogeneity, or if the concentration of antibody is too low. Can there be a discrepancy in ISC and ISH results? Yes, there can be a discrepancy in ISC and ISH results. What are the reasons? But they are only 5% cases where there can be a discrepancy. And these cases are those cases where either the HER2 is overexpressed due to reason which is other than amplification, or the condition where HER2 is amplified for a reason which is other than overexpression, or there is intratumor heterogeneity. But these cases should not be more than 5%. If you are not getting the results of in situ hybridization, there are many causes, but the four most common causes are that the fixation time is more than 1 week, or fixation is done in any other fixative other than 10% neutral buffered formalin, or fixation involves acid, especially in the bone biopsies from the metastatic side, or there is insufficient protease treatment. Now, what is HER2 low and why this category is required? Because until recently, only HER2 positive cases were eligible for the anti-HER2 therapy. It's only after the result of Destiny 4 trial that low HER2 cases are clinically targetable, and therefore FDA has given approval for this drug as a first HER2 directed therapy for HER2 low cases. So why are we targeting the HER2 low cases? Phase 3 Destiny 4 trial evaluated the safety and efficacy of this drug in HER2 low tumors, and it showed that there is a longer progression-free survival and overall survival when HER2 low cases are treated with this new drug ADC in comparison to the chemotherapy. And therefore, FDA has given approval to this drug, and that is why we are targeting HER2 low cases. How does it act? How does this new drug act? See, this is a cell where this is a HER2 protein and this is a ADC, that is antibody and chemotherapy drug conjugate. Now, once this ADC attached to this HER2 protein receptor on the cell, it gets internalized. After internalization, it disintegrates so that this HER2 receptor is separate and the drugs and antibody conjugate is disintegrated. Now, once this chemotherapy drug is free, it can enter the cell. Also, it is permeable to the cell membrane and it can enter the nearby cell. And importantly, you can see that this cell is not having any receptor, HER2 receptor, but still this drug can enter this cell and can show its effect. And this is how the concept of low HER2 came into evaluation. Like there are many nearby cells which are not having any HER2 receptor and still they are affected by this drug. And so that even if the HER2 positivity is very low, this ADC can show its effect. And this method of drug action is called bystander anti-tumoral effect. So majority of the HER2 low cases are hormone receptor positive. 80% of the hormone receptor positive HER2 negative cases and approximately 60% of the triple negative cases are classified as HER2 low cases. Majority of the HER2 low cases are show PIK3 mutation and they have less likely to have P53 mutation. So this HER2 low is not a biologically distinct breast cancer type, but is a therapeutic target for this newer drug. So where are we standing now? What is the current classification? So ISC can be 0, 1 plus, 2 plus, 2 plus with H negative, positive and 3 plus. So the traditional HER2 categories were HER2 negative up to here and HER2 positive, these two categories. But after this Destiny 4 trial, the currently targeted group is this ISC 1 plus and ISC 2 plus with H negative. This is the category which is called low HER2 category and they can be benefited by this ADC. And this HER2 positive stands same. And what is the potential future? Potential future is that this ISC 0 group can be subdivided into HER2 null where there is no staining and HER2 more than 1, more than 0, less than 1, which is called ultra low positivity. And this is being studied in the under study in the breast Destiny 06 trial. So what are the current challenges in HER2 reporting? So first challenge is that how to assess HER2 low cases. How can we assess HER2 low cases when they have already been reported as 0, 1 plus or 2 plus? So the answer to this is that training of the pathologist on low end HER2 expression scoring. Because after training, 87% of the samples which were scored as a 1 plus or 2 plus and 30% of the samples which were scored as 0 were rescored as HER2 low by the same pathologist after receiving the HER2 low scoring training. Then the other challenge is how to identify the cases who will now be benefited by this ADC. So answer to this is either you rescore the sample which were previously identified as ISC 0. Reason being because previously this low category was not existing. So pathologists didn't strive to distinguish between these two categories. Other way is that you score the metastatic site if primary site is ISC is 0 or metastatic site if not available for the biopsy, then the primary site can be re-evaluated or the re-biopsy of the primary site and the scoring can be done if the disease is on the progression. As per guidelines, both Ventana and non-Ventana platforms can be used for low HER2 scoring. So what are the future prospects of HER2 scoring? See, as per the current guidelines, only highest level of staining in more than 10% tumor cells are to be recorded. So you can see here in this figure that say for example, if this purple color is highest level of staining, if this is seen in more than 10%, we would have called it as ISC positive. But now as a future prospect, you can see the heterogeneity. There are some cells which are showing light staining. There are some cells which are showing dark staining. There are some other cells which are showing this type of staining and there are other type of cells which are showing this type of staining. So as a future prospect, the intratumoral heterogeneity need to be recorded, meaning thereby what percent of cells are showing 0 positivity, 1 plus positivity, 2 plus and 3 plus. So the proportion of cells showing individual positivity need to be reported in your report. And the second thing is pattern of heterogeneity. What do we mean by pattern of heterogeneity? See, here in this figure, these cells are negative and these cells are considered positive. So what is happening to the positive cells? They are intermingled with the negative cells in a haphazard manner. So this is called mosaic type of positivity. You can better appreciate it in this this slide, this figure. Suppose that green color leaves are positive and yellow color are negative. So you can see that there is no pattern of distribution of these green cells among the yellow leaves. So this is called mosaic type of heterogeneity. What is happening in this figure? You can see only red color flowers here forming a clone and green color flowers here forming a different clone. There is no intermingling of two different colors. So this is called clonal type of heterogeneity. Then the new category of scoring, which is called ultra low positivity, also need to be reported. Other future prospects are that the digital pathology and computational methods, they may improve the subjective variability. They may remove the subjective variability in HER2 scoring. And AI-based quantitative image analysis. For this, we should develop more computer algorithm to analyze images, quantify HER2 membrane staining, and to provide accurate and reproducible scoring results. So there are many studies on AI-based evaluation of HER2 by ISC and ASH, but majority of them digitalize only individual steps in workup of the HER2 status. And there is moderate agreement between pathologist assessed slides and AI on ISC. And most discrepancies occur between 0 and 1 plus score. Pathologist agreement with AI score is approximately 80% for ISC, and there is substantial agreement for AI and pathologist in the ISH. I am happy to share that I am a part of a collaborative study with the molecular biologist, medical genetist, and IT team, and other pathologists, where we are developing a software for the complete digital AI-assisted workflow, including both ISC and ISH, for determining HER2 status in primary as well as metastatic breast cancer. In this collaborative work, in the first phase, we are developing a software, and in second phase, we'll be correlating the findings of pathology assessment versus AI assessment. And once it is in the agreeable concordance, we'll be launching this software. So the other future prospects are that should we include this low HER2 category to other solid tumors also? Why? Because FDA has approved the benefit of this ADC in HER2 positive gastric or GE cancers and lung cancers. But still, the low HER2 category has not been categorized. So the conclusion is that Destiny 04 trial has because of the results of Destiny 4 trial, the FDA has given approval for the ADC for HER2 low breast cancer cases, and the re-evaluation of ISC 0 samples may identify patients who are actually now eligible for this ADC treatment. So the take-home message is that until the predictive value of novel assay of IA by AI is established, ISC remains the main appropriate tool for identifying the low HER2 breast cancers. Careful evaluation of IC 0 sample is now prudent. Whenever you are discriminating between ISC 0 and 1 plus, examine the slide in high power. Consider the second pathologist review if there is any discrepancy in 0 and 1 plus. And use the control which range with a range of protein overexpression including ISC1, meaning thereby you should customize your control by the microarray, and you can put 4 different type of breast tumors showing 0, 1 plus, 2 plus, and 3 plus category R2 category, so that when you have any discrepancy in deciding for the 0 or 1 plus or 2 plus, your control is readily available. And careful attention should be paid to the pre-analytic variables. Thank you.
So thank you, Dr. Anjali. That was very insightful session and very informative as well. And we have received compliment from Dr. Naresh Somani himself. Dr. Lakshmi has put up a question. The difference between overexpression and amplification, and can ultra low be used in stomach cancer?
See, as of now, there are no guidelines how HER2 low are to be actually recorded in the non-breast cancers. So, Destiny 6 trial has, yes, studied the effect in the breast cancers, but in other solid tumors, the FDA has given approval for this drug, but how to low categories to be decided is not yet, the guidelines have not yet being released for this.
Any other questions from?
I can see Dr. Somani sir, and thank you sir for joining. And if you can further elaborate or can comment something to make it more complete, I would be more than happy.
Thank you, and congratulate you for the wonderful talk to make it simpler for the clinician like me. And it is a need of the hour that we just don't report like the HER negative. Rather, even there is a now the term like the ultra low, that is between the 0 and the 1, because probably these are the patients who will be benefited, and we need to revisit our samples. Maybe the repeat biopsy, maybe the old biopsy, maybe the primary site, maybe the primary and secondary, both sides. So we should not leave any stone unturned to exactly characterize and to find out by the deep diving that who are the patient like 1, 2 with the FISH negative, where ADC can work. Regarding the other solid tumors, this HER is now used as the pan agnostic marker, tumor agnostic marker, that you can use it across the various malignancies if the HER is positive. Though benefit is less contrast to the breast cancer and the stomach cancer. But yes, it can be applied in the NSCLC also, endometrial malignancy also, like the tumor agnostic marker. And this benefit is largely limited to the FISH positive or the 3 plus positive patient across the various solid tumors. Lower is the HER positivity, less is the benefit. But yes, there is benefit. So until you have the absolute zero, this drug may be looked as the subsequent line of the treatment. This is what I would like to say.
Thank you, sir. And I think we can do a collaborative study, at least for the Jaipur centers, wherein we can rescore the ISC 0, 1 plus and 2 plus, and to find out where our patients fall, how many percentage of our patient fall into low HER2 category, which can actually be benefited by this ADC.
There
And
are
I would
other
also,
few sorry,
yes,
sorry.
and I would also like to involve you into that collaborative study, wherein we are developing the software for HER2 scoring by AI for ISH as well as for ISC for both primary and metastatic cancers. And once this software is developed, we will be actually correlating the pathologist assessment with AI. And once it is in the agreeable concordance, then we'll be launching.
So definitely it will be really helpful for us if Dr. Somani joins us for this validation studies. There are a few more questions from other team members. Can we incorporate ultra low HER2 NEU in our reports? That's what I.
See, it was there in the Destiny 6 trial, but exactly the CAP guidelines do not give the use of the support of use of this term, ultra low. Yes, of course, low HER2 is there in the latest CAP guidelines, but ultra low is as of now not there.
So there's another question. Considering the heterogeneity, how many minimum sections are required for taking?
See, ideally, per centimeter of the tumor should be sampled to see the exact results. If you have not given sufficient number, if the tumor is of 5 centimeter size, then of course 5 samples you are supposed to study, and then only you can decide for the heterogeneity.
So Dr. Lakshmi has put up a question. Is it helpful in urethral cancer?
I have not come across, and neither I have seen any published study in the literature for the urethral cancers.
So any other questions from?
I think Somani sir, if he is aware about the urethral cancers, you can sir answer this question. Do you have any
Sorry, as I
experience?
just commented, it is a tumor agnostic marker. You can use it across the various malignancies. Previously, the other available drugs like the trastuzumab, other drug combination, TDM1, they have been attempted, but with the miserable results or with the disappointing result. But with this particular antibody drug conjugate, that is the trastuzumab deruxtecan, there are improvement in the results. And probably based on these sort of the ADC, now it can be used as the tumor agnostic marker, including urothelial malignancy, though the incidence is very, very low.
Okay. I mean, in G, at the G junction tumors, gastric tumors, and in lung cancers, I have come across many papers, but for the urethral,
No, same applies to colorectal malignancy also.
Okay.
Other than the RAS mutation, nowadays we study everyone for the MSI as well as for the HER also. and for that matter, gallbladder also.
Okay. PAN-GI, I think.
Yeah. Yes, it's a pan GI. Biliary tract, that is the cholangiocarcinoma also. Incidence in the pan malignancy is very, very less.
Thank you, sir. Thank you.
Thank you.
Thank you so much, sir.
Yeah. So I think we don't have any other questions. Any more questions from Dr. Anjali, Dr. Somani?
I think Somani sir has made it more complete by the
Yes,
concluding remarks.
Right. So thank you all for joining in, and Dr. Anjali, it was definitely a wonderful session. Thanks for giving so much of information in a very simplified way, and we keep on having such sessions in future as well. So thank you all for joining. I'm ending this session here only.